Chapter 2, Lecture 4. In this lecture, we overview some empirical evidence about the impact of different input factors on health production. But before that, I wanted to review the graphs that we had previously because understanding this graph helps you to understand the impact of different factors on healthcare production. Remember that we had this graph that the medical care or amount of medical care we use is in the horizontal axis, and then amount of the health in the vertical axis. So, and then we said that there is a positive relationship between amount of medical care and the health. Means that by basically consumption of medical care, you increase your health, but this is increasing in the decreasing rate. It means that there is a diminishing marginal productivity of health, like any other production of any other goods and services, basically. So starting with the TP, if there was a technological change in one of the medical care, say that is affecting the medical care, so we are going to have a shift upward of this total production. Although this shift is not going to change the intercept. Remember, the interception, it depends on our profile. A baseline profile depends on just basically the status of genetic and all the age and factors, mental and health status that we have. Until anything change those, then we are not going to have a just parallel shift. We are going to have a rotation in this case, unless something changed this profile, and that could be change in like say that if we have an illness or something like that, that shifts. Anyway, the point here is that this rotation means that in each point we are going to have a higher level of health by the same amount, by consuming the same amount of medical care. We are going to have a higher amount of total health. So what is the meaning of movement of say that change from point A to B? So it is very important, or from, for example, change from C to B or A to C. So it's very important to understand these movements. In economics, we have two changes in the graph. One is movement along the curve from C to B, which this C to B is basically depends on the amount of medical care we are consuming, and so it's movement along the curve, assuming all else being equal. Ceteris paribus means that all the other factors are constant. Even technology is constant in this curve. So if we move from C to A, then that actually is assuming a decrease in technology. But if we move from A to C, this means that with the same, actually means that we consume less amount of medical care to get the same amount of health, basically, from A to C. And the good example would be different, say that medical care that they're giving us the same amount of health, but say that, for example, treatment in cancer care, you need probably less cancer treatment cycle and resources to get the same amount of health. So this is actually moving from Q0 to Q2, which is showing us a cost saving of that specific type of treatment. So treatment C is much cost saving than treatment A, with this, basically upward sloping of the new technology. But um, if we use, older product, so means that we need more resources to get the same amount of basically care. And then movement along the C to B, it means that in the same technology means that everything else the same. The only thing you're changing here is just the medical care to change your total health. So movement along the curve is just the depends on the change in the medical care to change the health. And then what does it mean the movement from point A to B? So from point A to B, this is actually is in your book. You see sometimes upward shift or the rightward shift. This is both. This is upward and it is rightward from point A to B. That means that, with the better technology, everybody wanted to have that new technology, so they actually spend more to get better health. And this is like a movement from A to B. The good example is like, for example, knee replacement surgery these days. Everybody wanted to have it because it's much actually cost effective. Um, but so I guess this has a lot of applications. If you learn that what is the move from A to B, A to C, or C to B, and you have to just differentiate that. The only thing actually differentiate the movement along the curve and then the rightward or the leftward or upward shift. Now let's move to the empirical evidence. We usually in the empirical studies, we have to categorize our sample by age group. That's the biggest actually categorization. And after age group, we categorize by gender. So if you look at the impact of co-insurance plans on the basically on medical care and health, we can see that and so basically looking at the impact of a low co-insurance compared to those people they have a high co-insurance plan. The percentage of the insurance you have to pay basically. And assuming ceteris paribus means that everything else being equal, all the other factors are the same, environment the same, healthier lifestyle the same, your profile the same. So they find a small marginal impact of medical care services on the health status of adult. So this is what they found actually. There is no really statistically significant impact of the co-insurance plan on the medical care and health. Then looking at the non-elderly adult, looking at the basically the insurance, and we see that health insurance increases physicians and preventive services, improves self-reported health status, and lowers mortality conditions on injury and diseases. This is basically so the impact on, we are looking at the preventive services here is improving, increases the physicians and preventive services. Of course, if you have the insurance, so you're going to go to your primary doctor and preventive services, and then improve the health status and then lower the mortality rate. So the studies offer no direct estimates of the magnitude of the marginal productivity. So in the previous one, we had the, usually we like to have the, we like to quantify the amount of the impact. So we can actually use it in the policy, how we have to allocate our resources among different factors affecting. So then we look at the education and health. We see that always, we know there is a positive relationship between education and health. And if we wanted to look at the degree, one more year of schooling decreases the probability of dying within 10 years by 3.6%. This is huge. And an additional year of education increases life expectancy between 0.18 and zero point 0.6 years. If we look at the income and health, we know there is a positive connection between increasing income and health, of course, enhances both mental and physical health. Um, and we know that people with less than a high school education, so if basically they an income below 10,000, this is very specific that they have 2.3 times more likely to have functional limitations and poorer self-related health. So we already know there is a positive relationship between health and education, but we wanted to quantify that, and then we have the number here. In the short run, there is a inverse relationship between a strength of economy and health. This sounds kind of strange, but the point here is that what does it mean when there is a recession and unemployment rate is high? Then people, they have more time to spend for leisure, so they relax. And when there is a recession, I guess you don't have that stress that you're the only one, you don't have job, so you enjoy your time, the leisure time. So that's what the macroeconomists found that interesting. Um, Looking at so if you wanted to quantify, basically 1% drop in unemployment rate um, is actually decreasing the total mortality rate. That's interesting. So we can actually even quantify that and see how this unemployment rate is affecting the mortality rate. So when we are looking at income inequality and health, remember that in economics we always care about the relative values, not the absolute value. We care about the relative income, we care about the relative prices, because that actually it matters. If you're poor, you have a low income, and you live in a low income neighborhood, you're not that bad actually, mentally and physically, because you compare to your neighbor, you're almost average. But if you actually are living among a rich neighborhood, that has a very, very significant negative impact on your mental and physical health. So the other effect is lifestyle and health, and we know that risky lifestyle actually has a negative impact. But how much? We can measure that: smoking or excessive alcohol consumption. So we can see that, for example, a male expected to live 2 years less compared to the non-smokers. For female, expected to live 1.44 years less compared to the non-smoker. And then obesity, same impact on health as 20 years of aging. And adverse lifestyle caused the total product care for medical care to shift downward and possibly flatten. So those are huge. I'm going very fast because these are something that basically that, but the numbers are important that we wanted to see. The environment and health, the relation between environment factors and health is very complex in terms of specifically air pollution and water pollution and their impact on health. But some study shows the reduction in air pollution accounted for as much as 15% of the overall increase in life expectancy. So, and then we have the other factors, other determinants such as age and marital status, and some studies, not some studies, statistically they say that married adults experience better health. So these are, basically very controversial. Of course, it's changing over the time and depends on your sample. If this is a census data, and then this is basically is a national representative data that's saying that married people, they say that still they're, following a healthier lifestyle than non-married people. And children's health, long-term impact on adult health and education and social status. Means that, you know, basically that has a lifetime impact on whole day life. If they have a basically very poor health at the childhood, that is going to follow them all their life. Parental education positively, of course, impact the production of the child's health in old age again, even after the adulthood, in the labor market. That was actually my part of my PhD dissertation, looking at the impact of parental mental health on children's graduate probability of graduating from high school. And then after that, even looking at even when they go to the labor market, how is affecting their labor market outcomes, such as wage and probability of having full-time job. Environmental factors also impact children's health, and expansion of Medicaid eligibility impact infant mortality. And so that's actually, it's very important, the Medicaid expansion of Medicaid in the infant mortality. So some study, they can probably look at the states they have the expansion of Medicaid compared to the state they don't have, and look at the impact of infant mortality. The determinant of the health among elderly, we know that Medicare utilization of the is impacting the utilization of ambulatory and inpatient care, increases sharply at the age of 65, because most of the people, they wait actually to get their Medicaid, and to those people, they don't have a good medical insurance. So far that was the case. And basically there are relatively large and marginal productivity when we are looking at the impact of Medicare on elderly population. So remember that in adult, non-elderly, it wasn't a significant marginal productivity of insurance, but in this case it is. So that actually, there is a significant association with the more medical spending and procedures, and reduction in mortality rate of elderly. Means that, when they have the medical care, Medicare, basically they use it in the preventive cases, not to actually less time in bed, and also a reduction in mortality rate of elderly. And the public health intervention, specifically we are talking here about the development of the clean water or clean air in the United States during the first half of the 12th century. Improvement in nutrition and health and public health actually significantly decreased the infectious disease mortality rate. So what does it mean? In policy implication means that we have to invest in clean water technology. So this is as important, investing in clean water is as important as treatment, basically. Or looking at the development of the polio vaccine, number of the reported polio cases fell by approximately 90% within a span of 2 years. What does this mean? It means, statistically, you can say that, hey, 90% within 2 years. So it shows the cost effectiveness of vaccine compared to somebody who look at one case and say that, hey, maybe vaccine actually causing basically, those people there against vaccine, basically they say that I know this autistic kid, that it happened after vaccination. So there are so many other factors you have to basically control. Over the course of a year, more than 2.4 million individuals died in the United States, and if we want this, the researchers, they found that 75% of those, they actually uh, they died from 10 most common cause of health, which basically those are like such as heart disease and lung cancer, which was basically lung cancer. 80% um, is related to the smoking. So the point here is that these among these 2.4 million people, they died. 75% died from um, cases related to the lifestyle choices, socioeconomic status, environmental factors that can be actually prevented. And so, so why do we actually look at this empirical study? Because we wanted to um, help the decision makers to allocate the resources in the right place. Um, or cost-effective policy can design, for example, for um, medical care matters but um, non-medical factors also play an important role in maintaining wellness and better lifestyle. So it's not just only spending on the medical cases. So when we are looking at those shift in the productivity, product of health, and movement along the care, shift could be by the environment, by healthier lifestyle, and then um, so those are the factors that are actually um, are sometimes even more important than medical care. So those are the implications for the policy implication that help us for um, raising, for example, when you're allocating your resources, you have to basically know that even raising education level or spending money on education or um, reducing the amount of poverty or encouraging improved lifestyle, they are all as important as in education. So that's why the implication of the Patient Protection and Affordable Care Act of 2010 is actually helped the American people to take care of the first actually aim out of triple aim. As you know, triple aim means that higher access to care and by better quality of care, and then the third one is lower cost per capita. So from this triple aim that can actually help us in making our healthcare system to be more cost effective, the first aim is already done. Basically, we approach the first aim of access. So we have to now think about the how make our healthcare system more cost effective, and that would be basically emphasizing on the healthier lifestyle and environment and education, even as well as treatment and medical care. So this actually concludes our chapter 2.